question concerning the lab exam? All right, so the lab exam is not available yet. As we've mentioned, the lab exam is going to be available just 1 week before due date. All right, so where can you find the lab exam? Is going to be under the proctored, smarter proctoring. All right, does this answer your question for those who are asking? Can you hear me? Oh. All right, so it's going to be one available for you 1 week before the due date. All right. Yes, I know that you can see on Canvas lab exam 4, lab exam 3, and the final exam. Yes, I know this. They are available, but they are not available for you to complete. All right, they will become available for you to complete just 1 week before the due date. For lab exam 1, it's not available at all because I have to create it from scratch. Why the other ones are available on Canvas? Because they are older versions that got modified, so they are ready to complete. But this one I have to create it from scratch, so it's not ready yet for me to post it on Canvas to appear on your syllabus, which is not your syllabus. Canvas syllabus is not a syllabus. This is just everything that you have to complete through Canvas, but it's not the only things you need to complete. All right, so just make sure you are following the actual syllabus, not the Canvas syllabus. Canvas is just showing you the activities that are going to be conducted through Canvas. Is this clear? Any questions? Any questions? All right, so we're looking here at the capillary exchange of the respiratory gases and nutrients. First major way by which the gases and nutrients going to be transported is going to be by diffusion, and diffusion means I am allowing the solutes to pass from a high concentration gradient to a lower concentration gradient. Same way will be for the carbon dioxide and the metabolic waste, but this time the tissues are the ones that will have high waste and high carbon dioxide levels compared to the blood vessels, which will have lower waste and lower carbon dioxide levels, allowing the waste and carbon dioxide to diffuse from the cells to the vessels. Lipid-soluble molecules will diffuse directly through the endothelial membrane, so you don't need to have any carrier or any transporter to allow the lipid-soluble molecules to travel. They can simply pass through the plasma membrane of the endothelial cells. Water-soluble substances and molecules are going to be able to travel only through clefts and fenestrations. If you remember, when we studied the capillaries according to their structure, we mentioned that the continuous capillaries, the only way for them to transport fluids and solutes is going to be through the intercellular clefts, which are those tiny pathways between the cells. And in the fenestrated capillaries and the sinusoidal capillaries, they did have their endothelial cells were fenestrated like this, so they have pores through which the fluids and solids can pass, and even cells in the sinusoidal capillary. Large molecules such as proteins are going to be transported by active transport by pinocytosis. If you remember, a type of active membrane transport that we've studied back in AP1 was the vesicular transport. And we classified the vesicular transport into two main types. If you are passing something from outside in, we call this as endocytosis. And if you are moving something from inside out of the cell, this is exocytosis. If you remember, endocytosis was also subclassified into two main types. If you are engulfing a solid particle to the inside of the cells, this is like eating, so we call this as phagocytosis. And if you are engulfing fluid-based substance that will contain whatever elements that you are moving in, we call this as pinocytosis or pinocytosis. So if I'm trying to transport large chemical compounds, the best way for me is to allow this to take place by pinocytic vesicles through pinocytosis. So again, diffusion of the lipid-soluble substances can simply be taken place through the plasma membranes of my endothelial cells. I have no problem with that. Movement of the water-soluble substance, this is going to be taking place between the cells through the intercellular clefts or through the fenestrations located inside the endothelium. If you are transporting larger chemical compounds, they will require a vesicular transport in which you form a vesicle that will be surrounding the substance in a liquid form. We call this as pinocytosis. For the second question for today, what do you think here is the blood flow through the tissues? What do we call the blood flow through the tissues? Is it diffusion, tissue perfusion, autoregulation, none of the above? Allowing the blood or fluid to travel between the cells in a tissue is what we call a tissue perfusion. Exactly. Tissue perfusion. Moving on to the homeostatic imbalances that are related to the blood vessels. First, we get the varicose veins. And varicose veins, those are dilated veins due to leaky valves. They are not uncommon. They are present in almost 15% of adults. They usually appear in the lower limbs. Also, it's common to see them in the anal veins. What is the problem in here? If you remember, the veins did have thin wall compared to the walls of the arches, and they normally have a large lumen. That's why we call the veins, they are the capacitance vessels. Because remember, 65% of the blood volume is going to be kept inside those veins. But something that we need to be aware of, that those veins cannot tolerate high pressure. So if the blood kept accumulating inside those vessels, inside the veins, the wall of the veins cannot tolerate the high pressure, and it will start to form balloons filled with blood. Dilation in the walls of the veins. And those pouches filled with blood on here, those are the varicose veins. What is the main triggering factor for the development of varicose veins? If you remember, in order for me to push the blood up back to the heart, I did rely on the presence of the veins surrounded by my skeletal muscles. So the muscular pump is going to be responsible to squeeze the veins in order to create a state of high blood pressure within the vein. And this high pressure is going to be driving the blood either upwards or downwards, according to whether or not you have normal functioning valves. So if I have normal functioning valves, the only way for the blood is to flow upwards towards my right atrium. So we're looking here at the leg veins, for example. You're squeezing the blood is going to be allowed to move up and will not be allowed to move down. What if I have a collagen problem and my valves in the veins are leaking? So each time I increase the pressure within the veins, some of the blood gonna be able to return down with the gravity. Squeezing blood is supposed to move up, some of it moves down. So what happens over time, rather than containing this amount of blood, the amount of blood that will be located in the veins now, because it has a thin wall, it's gonna be distending, forming those sacs filled with blood. Those are, again, my varicose veins. What's common? Most likely they won't be a threat. Like they are not life-threatening. All right, so you're asking, is it for a treatment? All right, I'm sorry. I thought you're asking about the threat. So first, to answer threat, so they are not imposing major threat unless it's affecting deep veins. Most likely the varicose veins are going to be affecting superficial veins. And the major manifestations of the varicose veins are going to be, if extensive, will be skin discoloration, discomfort in the legs. Treatment is going to be to remove the vein. So you just remove the vein. If it was a big superficial vein, you're going to remove the vein. Or if it was a small vein, you're going to be injecting the vein with a substance similar to super glue that will be obliterating the vein. This is sclerotherapy. Sclerotherapy is going to be used in smaller veins, and if I have extensive varicose veins affecting my large superficial veins, at this point I will need to get them removed. All right? But most likely, people won't even develop symptoms unless they have very extensive varicose veins affecting all the three major superficial leg veins. Moving on to another set of homeostatic imbalances that will be related to the vascular system is going to be the alterations in the blood pressure. So if I have a low blood pressure below 100 millimeter mercury for the systolic, this is going to be considered a hypotension. And hypotension is often associated with long life and lack of cardiovascular illness. So why long life is a risk factor or a precursor for the development of hypotension? Remember, in order for me to drive the blood up back to the heart, I would need skeletal muscles. So what happens when a person gets older is weakening of those muscles. So as I lose my muscle bulk, my ability to move blood back to the heart is going to be reduced. And as I have a reduction in my venous return, remember, this is my right atrium on here. Right ventricle. So if I have less venous return going to the heart, so this will directly reduce the amount that will be pumped towards the lungs and will definitely be reducing the amount going back to the left side of the heart. And as a result, less blood gonna be pumped out. This will cause a reduction in the stroke volume. Remember, when we studied the stroke volume, we mentioned three major factors that will be affecting stroke volume. And one of them was the preload. And the preload in here is gonna be the blood returning back to the heart, the venous return. So if I have a drop in my preload, in other words, venous return, I have a reduction in my stroke volume. And so, if you remember, cardiac output was equal to stroke volume times heart rate. So if you have a reduction in stroke volume, you're gonna have, as a result, a reduction in the cardiac output. And remember, what was the mean arterial pressure equals to is cardiac output times total peripheral resistance. So if I had a drop in my cardiac output in here, this will directly reduce my mean arterial pressure, resulting in a hypotension. All right, so again, why long life is a risk factor for developing hypotension? Because of the weakening of skeletal muscles, resulting in a reduction in the amount of blood returning back to the heart. And so this is gonna be manifested as a reduction in stroke volume, cardiac output, and so blood pressure. Another imbalance, homeostatic imbalance that will be related to the blood pressure is going to be the hypertension. In order for me to consider a person as hypertensive, he has to have a blood pressure of at least 140 over 90 or higher. So if I am 140/90, it's still borderline. So in order for me to think of a definitive hypertension, it needs to be greater than this number. Also, another thing that I need to pay attention to is that this high blood pressure needs to be sustained, elevated. So what this means that you don't simply take a single blood measurement in order for you to decide whether the person is hypertensive or not, because blood pressure is going to be affected by fever, physical exertion, emotional upset, and those are transient adaptations to the blood pressure. This doesn't mean that the person who is upset has hypertension. He will have high blood pressure, but it's just transient increase. It's not a sustained elevation in his blood pressure. Moving on to shock. So what is meant by shock if you are in shock of somebody? When would you be shocked in somebody? What do you think? Trauma? Like, what a life situation would you be shocked in somebody? So, I'm shocked. What do you think? Car accident? Less. Like, have you been shocked in somebody? Like moral shock? Moral shock, not an actual vascular shock, right? When would you be shocked in somebody if you are expecting, yeah, emotional shock? What do you think? If you're expecting something to be done and it's not, if you're expecting somebody to do something for you and he didn't or she didn't, so you're shocked, right? So emotional. So this is just to remind you of shock. I was expecting something and it didn't happen. So who is shocked actually is your body organs. What they were expecting the cardiovascular system to deliver enough blood for them to meet their metabolic needs. All right, so when you're shocked in somebody, he is just not meeting your expectations. Same for the organs on here. So the cardiovascular system is not meeting the expectations of your organs. So this is shock. All right, this is just for you to remember. So again, what's by definition is shock? I don't have enough supply to my organs. What might cause shock? What might cause a vascular shock or shock in general? I might have a problem in the amount of blood. I don't have enough blood, so my heart is fine, my blood vessels are fine, but the problem is, as you mentioned, person got in a car accident, he lost large amounts of blood. So, and as he loses large amounts of blood, he has a drop in his blood pressure, because remember, blood pressure is cardiac output times resistance. And if I have a drop in my blood volume, this is gonna reduce my cardiac output and will cause a major drop in my blood pressure. And this results in what? This results in reduction in the tissue perfusion. So I'm not meeting the expectations of the organs. So what is the reason here for the shock is blood. So what do we call this type of shock? It's hypovolemic shock. So it's a shock. I'm not supplying enough blood to my tissues. I'm not meeting the tissue needs. Due to what? Due to hypo means low, volume, and emia blood. So again, what is the reason here for the shock is a drop in my blood volume, hypovolemic shock. So what might cause hypovolemic shock? Hemorrhage. If I have loss of fluids in large amounts, for example, severe vomiting or diarrhea. Burns, extensive burns can also result in a hypovolemic shock because remember in burns, the burn site is going to be oozing plasma, it's going to be oozing fluid out. So this is going to be dropping my blood volume and so my blood pressure and tissue perfusion. So now I have a hypovolemic shock. What else might cause shock if I am not having enough vascular tone? Remember what's shock? Shock is low tissue perfusion. And low tissue perfusion means for me is that I don't have enough blood pressure. I have a major drop in my blood pressure. And remember, what is the blood pressure? What are the main factors? Cardiac output, total peripheral resistance, and blood volume. So here, the problem is in the resistance. I have anaphylaxis. I have hypersensitivity. I got exposed to an antigen that I have hypersensitivity for. And remember, when you get exposed to a foreign antigen, how your body responds, it responds by having inflammation. Well, this is an extensive inflammation. And if you are looking at an inflamed site, how will it look like? If I told you I have inflammation in my elbow, what do you expect to see in my elbow? It's going to be swollen, it's going to be red, it's going to be hot, painful, tender, right? So inflammation, what causes the actual inflammation is a dilation of the vessel. So what happens at an inflamed site is simply a dilation of the arteries or the arterioles supplying the inflamed site. So you're going to get more blood delivered, and that's why what will make it red, what will make it hot, and due to the passage of large amounts of fluids, as I'm getting more blood into the capillary beds at the inflamed site, more fluid is going to be passing between the cells, so it's going to be swollen. So if I choose one word to describe inflammation, is going to be vasodilation. Dilate the vessels. So here I have an abnormal inflammatory response, a major inflammatory response, like in case of anaphylaxis, or if I got exposed to bacteria and toxins in my blood. So my immune system is going to be mediating a very extensive inflammation. So, and again, what's inflammation in one word? One word, what is inflammation again? Vasodilation. So if I dilated a huge number of arterioles in my body, what's going to happen to my total peripheral resistance? Would there be an increase or a decrease in the total peripheral resistance, in the amount of resistance that is facing the blood flow? What do you think? If you dilate all the vessels, dilation of all the vessels, would I have high or low resistance? Low, very, very low. So I have a major drop in my total peripheral resistance if I have extensive vasodilation. And as a result, what's going to happen to my blood pressure? If I have a major drop in my total peripheral resistance, this is going to result in major drop in your mean arterial pressure, and so a drop in the tissue perfusion. Drop in the tissue perfusion is what we're going to call here shock. So again, what type of shock are we looking at in here? It's a shock caused by the dilation of the vessels. So what is the reason of the shock is the blood vessels. So we're going to call this is my vascular shock. Vascular shock. Again, mean arterial pressure is going to be affected by three major factors: cardiac output, total peripheral resistance, and blood volume. So this time, I don't have any problem with my vessels. So I have a total peripheral resistance, normal total peripheral resistance. I don't have a problem with my blood volume. I have a normal blood volume. My problem now is with the cardiac output. What is the problem here? The problem is person, for example, got multiple myocardial infarctions. So what's going to happen to the force by which the heart is going to be contracting? What do you think? If I have multiple myocardial infarction, multiple parts of the heart are dead and got replaced with fibrous tissue, would you be able to perform the same contraction as before? What do you think? Or will it be decreased? What do you think? I will have a drop in my contractility. And if I have a drop in my contractility, if you remember, this is one of the three main factors that was affecting my stroke volume. So if I have a decrease in contractility, what's going to happen to the stroke volume, the amount of blood that I pump from the ventricle per beat? What's going to happen to the amount that I pump per beat if I have less muscles? Yeah, I will have a drop in stroke volume. And can you remind me what was the cardiac output? Cardiac output was the amount of blood that I pump per minute. So here, stroke volume, once it's decreased, it's gonna definitely reduce the amount of blood that I pump per minute. If I have a reduction in cardiac output, how's this gonna affect my blood pressure? Remember, mean arterial pressure is cardiac output times total peripheral resistance. So what's gonna happen to mean arterial pressure? Decline. So decline in the mean arterial pressure gonna result in what in terms of tissue perfusion? If I have a drop in my blood pressure, I will have a major decline in tissue perfusion, and this won't meet the tissue needs. I am in shock. But what is the reason of the shock in here? Is it the blood vessels? No. My blood vessels are fine. Is it my blood volume? No. It's my heart. So the reason for the shock here is the heart. So what we're going to call this type of shock, it's the shock that is generated from the heart. So we call it cardiogenic shock. So again, how many types of circulatory shock that we've seen? We've seen 3 different types. Again, if I have a loss of my blood volume, a drop in my blood volume going to result in hypovolemic shock, major dilation of the arterioles, like in case of anaphylaxis or septicemia. This is going to be a vascular shock, having a major reduction in the contractility of the heart, going to result in a cardiogenic shock, and this is going to be manifested in case of multiple myocardial infarction. Looking here at a major homeostatic imbalance, which is the atherosclerosis. Atherosclerosis is going to be due to the accumulation of fat in the wall of the vessel. This will reduce the diameter available for the blood to flow. It might be manifested as the angina pectoris, as what we've seen in the heart. If I've got a rupture of this atherosclerotic plaques, this will create a rough surface for the activation of the platelets to take place, and the blood clot might be formed occluding the vessel, and this is what will cause a myocardial infarction. All right. Questions? Risk factors. One of the highest risk factors for developing atherosclerosis is the increase of the low density lipoproteins, or LDL, in the blood. So high LDL carries the highest risk for developing atherosclerosis. And this is a bad type of fat. Bad type of fat is the LDL. HDL is not associated with atherosclerosis. So it carries much lower risk of developing atherosclerosis. The one that carries the highest risk for developing atherosclerosis is the low density lipoproteins, not the high density lipoproteins. Questions? All right, so we'll go over the important diagrams with you, and I will mention also, I will discuss with you a set of vessels that we didn't discuss before. Also, how I will be rating those diagrams, and I will rate them according to their importance into different levels. 5 stars means they are highly important. And as you go down to 1 star, it's much less important. So a diagram which is very important is going to be a 5 stars diagram. Less important is going to be 4, 3, 2, 1, and so on. So this will give you an idea on how to prioritize the diagrams. All right, to have a better management of your time, of what you should be spending more time on and what you shouldn't be wasting a lot of time on. All right, so looking here at this first diagram, showing the differences between the structure of an artery and the structure of the vein. This is a 5 stars diagram, highly important. The most important thing is for you to remember the name of the different layers of the vessel: tunica intima, tunica media, and tunica externa. A 5 stars diagram. Not much to test you on, but it's a highly important diagram. I would rate it 3 stars or 2 stars because there is no much to memorize or study for this diagram. I want to make sure that you're able to identify which one is an artery and which one is a vein. Right, remember, how would I do this? How would I know which one is an artery, which one is a vein? The one with larger lumen, thin wall, this is my vein. And the one with thick wall and smaller lumen is going to be my artery. All right, so again, a 2 stars diagram. 2 stars diagram, it's very important to be able to differentiate between the artery and a vein under the microscope. Checking out the different blood vessels that we've discussed, you will be able to find those PowerPoint presentations with the highlighted markings. Those highlighted markings are the ones that we've covered in class, and those are the ones that I'm expecting you to know for the lab exam. So if it's not highlighted on those diagrams, this means it's not going to be important for you on the test. All the blood vessels that are highlighted are of high importance. So I would rate all of those diagrams as 5 stars diagrams. All of them are going to be of the same degree of importance. All of them going to be 5 stars diagrams. There are other diagrams in your textbook which are not important for us. They are illustrations for you to have a better understanding of what are the different vessels and where they are draining and so on. So this type of diagrams is a type that we're concerned with. All right, the realistic diagrams. Again, only the ones that are highlighted. Those are the ones I'm expecting you to know for the lab exam. All of those diagrams are showing the different blood vessels that you should know for the diagram part. And also they are going to be helpful for you to identify the different blood vessels in a pathway, in the blood pathway. With one exception, which is going to be this diagrams that we did not cover before. So all of the others going to be used for both the diagram part and the blood pathway part. The only one that is not going to be used for the blood pathway, you don't have to worry about it in terms of blood pathway. It's going to be the venous drainage of the brain. And when we look at the venous drainage of the brain, we can see on here a major vein that is located between the right and left cerebral hemispheres in the upper part. This is called my superior sagittal vein sinus, superior sagittal sinus. Below, still between the two cerebral hemispheres, is going to be my inferior sagittal sinus. And as you see on here, both superior and inferior sagittal sinuses are going to be connected by straight sinus. Straight sinus is the connection between the superior and the inferior sagittal sinuses. Those all will be drained in a vein that travels horizontally. This is called my transverse sinus. Transverse sinus will then drain into an S-shaped vessel that will carry the blood down to the outside of the skull. This S-shaped portion here is called the sigmoid sinus. Sigmoid sinus is going to drain the blood out of the skull through the internal jugular vein. Also, a really important sinus that we've got is the cavernous sinus. And the importance here of the cavernous sinus is that it's a connection between the venous drainage of the face. It's a connection between the venous drainage of the face and the brain. So that's why if a person got a facial infection, he needs to be not squeezing the infection to not get bacteria traveling towards the cavernous sinus and causing a brain infection. Most likely it won't happen for most of the people, but unless a person has a weakened immune system. For the blood pathway question, you will not be provided with a diagram, you're going to be provided with a list. So for example, if I'm asking you here, one is going to be the hepatic portal vein, and let's say all right, so you're going to have 2, 3, 4, 5, 6, 7, 8 here to complete. All right, and I give you number 9. It's going to be the pulmonary semilunar valve. All right, so can you please answer this as part of your in-class activity for today, starting from 2. I know that we did answer question number 2 before, but just add it on. All right, this is how a question on the lab exam gonna look like. I will be providing you with 2 points and the list in between that you're gonna be completing like this. But I will not be giving you a diagram. I'll give you 2 more minutes for us to check this question together. All right, so hepatic portal vein is gonna carry the blood where? What is your next station when you get to see hepatic portal vein? Where would you go? Liver. What's gonna happen? Where is the blood gonna be moving next? From the liver. What do you think? Remember, liver is drained by hepatic veins. And hepatic veins, remember, so we started from this point on here, hepatic portal vein. Then I will go to the liver. And remember, liver and kidney are gonna be drained directly to the inferior vena cava. So what is my next vessel that's gonna be draining the liver is gonna be my hepatic veins. Hepatic veins will carry the blood to my inferior vena cava, then to my right atrium, then I will pass through the tricuspid valve, then to the right ventricle, then to my pulmonary semilunar valve, which is my destination. So you see on here, what's gonna be the pathway in order to answer this question on here. So we did move from hepatic veins to the inferior vena cava, to the right atrium, to the tricuspid valve, to the right ventricle, and nothing on here. All right, if something like this, you're gonna have one of the choices as a blank answer. So you're gonna be picking a blank spot. All right, but this won't happen on the read exam. This won't happen on the read exam. All right. Let me try another exercise here, just for you to make sure that you understand the concept and you're ready to complete this kind of exercises. So we're starting from, let's say, right dorsalis pedis vein. And I'm going towards my left dorsalis pedis artery. This is not part of the in-class activity. This is just for practice. This is just for practice. What do you think? Right dorsalis pedis vein. What is your next station? First, you need to know where is the dorsalis pedis vein. Right dorsalis pedis vein. What's your next station? It's going to be anterior tibial vein. Exactly. Right anterior tibial vein. Remember, right anterior tibial vein is going to be moving up to drain the blood into my popliteal. Exactly. Right popliteal. Then right popliteal is going to be draining the blood up into my femoral vein. Remember, femoral vein is going up to travel below the inguinal ligament. This is where it's going to be draining the blood into my external iliac, right external iliac vein. Right external iliac vein, it's going to be draining up into my right common iliac vein. And right common iliac drains into, you remind me, what vein am I draining in here? Inferior vena cava, exactly. That goes up all the way to the chest to drain into what chamber of the heart? Right atrium. And then the blood gonna be moving to what chamber from the right atrium? And what valve? Travels through the tricuspid here to my right ventricle, then through the pulmonary semilunar valve to the pulmonary trunk to reach what organs? To reach the lungs. And from the lungs, we're going to be draining the oxygenated blood into pulmonary veins. Into what chamber of the heart that would be receiving this? To my left atrium. Allowing the blood to travel down through my mitral valve. And the blood moving down from the left atrium is going to be pumped out through from the left ventricle, passing through the aortic semilunar valve. Then I will pass ascending arch, and before I go to the arch, I need to ask myself, where am I going? Where am I going? I am reaching now the ascending aorta. What is my destination? My destination is the left dorsalis pedis arch. Left dorsalis pedis arch. So what will I do? I need to exit the aorta in its terminal branches. I'm going towards my lower limb. So I will go ascending aorta, aortic arch, descending, and I'm taking here the left side, so I will take the left common iliac artery, left common iliac artery, and I'm going towards the lower limb, so I will exit here from the groin region to the thigh through the left external iliac artery, and then left thigh in here. So I'm passing left external iliac, left femoral artery, left popliteal artery, left anterior tibial artery, and finally left dorsalis pedis. Any questions? Any questions? Anybody feels that he has a problem with this kind of questions? Any difficulty? Remember that in order for you to move from an organ to another organ, you're going to need to move back to the heart, to the lungs, and then back, and then be pumped out from the heart to reach the second organ. You cannot just travel from one organ to the other unless you're looking at the abdominal organs, which are directly connected to the liver. So those are the only two sets of organs that will be directly connected, and you don't have to go to the heart and lungs in order to reach the liver. All right, abdominal organs are going to be directly connected to the liver. All right, questions? So again, all those blood vessel diagrams are going to be of the same degree of importance. All of them are going to be rated 5 stars. You mean the diagram, or you want me to go over like how it moves? So we've got a question here. The pathway. So how, yes, this is here. You want the whole thing to appear in one page like this? Yes, all the veins and arteries diagrams are gonna be rated 5 stars, but you only need to know the ones which are highlighted. Only the ones that are highlighted. All right, so again, the blood pathway, the pulmonary circulation here. looking at. Remember, I've got here deoxygenated blood coming from the systemic organs. For the systemic organs located above the diaphragm, they would be drained through superior vena cava, and the systemic organs located below the diaphragm, they are going to be drained through the inferior vena cava to the right atrium. So if I'm draining a systemic organ, I need to get back to the right atrium, either through superior vena cava, inferior vena cava, or the coronary sinus if I'm draining the cardiac muscle itself. So the blood gonna do what after it reaches the right atrium? It's gonna be moving down through the tricuspid valve. And then it's gonna be pumped out from the heart, from the right ventricle, traveling up through the pulmonary semilunar valve, and then the pulmonary trunk, which splits into right and left pulmonary arches. To deliver the blood to my lungs. All right, any problem so far? So you go right, superior vena cava, inferior vena cava, to the right atrium, and then from the right atrium through the tricuspid valve to the right ventricle, through the pulmonary semilunar valve to the pulmonary trunk, then from the pulmonary trunk to the pulmonary artery to the lungs. Then in the lungs, I will be performing a gas exchange. So now the blood is coming out from the lungs oxygenated. And the oxygenated blood is going to be returning back to the heart. And remember, if I'm returning back to the heart, those are veins. And the veins that are draining the lungs, those are my pulmonary veins. Pulmonary veins are going to be draining the oxygenated blood coming from the lungs to my left atrium. And the blood here is going to be moving down from the left atrium to my left ventricle. And then from the left ventricle, it gets pumped out through the aortic semilunar valve into my ascending aorta. And then you're going to be getting out according from different parts of the aorta according to what organ that you are trying to reach, what organ are you trying to supply. But every time I'm moving to an organ, it's going to be coming from, the blood needs to be coming from the left ventricle passing through the aorta. But according to which side, which part of the aorta would you exit, this is going to be determined according to what organ are you trying to supply. All right, so this is pretty much everything related to the blood vessels. Let's now check the diagrams related to the heart. So the heart location in the chest, in the mediastinum, this is a diagram of lower importance. This is a 2 stars diagram. Nothing much to be tested on other than the pleura, the name of the vessels, the diaphragm on which the heart sits. So this is a lower diagram of lower importance. A 5 stars diagram is going to be showing the different layers of the wall of the heart. Remember, on the inside of the heart, we've got endocardium. Then we have the muscle layer of the heart. This is the myocardium, and to the outside of it, we've got the pericardium. And remember, we do have a serous pericardium, which is formed of 2 layers. And outside of the serous pericardium, we've got the thick fibrous connective tissue layer, which is my fibrous pericardium. So this is a highly important diagram, a 5 stars diagram. Another 5 stars diagram is going to be the diagram shows the different chambers of the heart as well as the associated blood vessels to it. 5 stars diagram. A 10 stars diagram is going to be showing the chambers of the heart, the valves, internal structure of the ventricles. This diagram is a must be on your test. There is no way I can test you on the cardiovascular system without having this diagram or a similar one on your exam. 10 stars out of 5, it's a must be on your test. Must be on your exam. Every single marking here is of great importance. Must be on your test. A 5 stars diagram shows the different coronary arches. Remember, right and left coronary arches and their main branches, those are of great importance. It's very important for you to be able to identify circumflex artery, left common carotid, left coronary artery, circumflex artery, anterior interventricular artery. It's very important to identify right coronary artery, right marginal artery, and on the posterior side to identify the posterior interventricular artery. All those coronary arteries are highly important for the exam, and this diagram is going to be a 5 stars diagram. A 2 stars diagram is showing the venous drainage of the heart. The only marking I want you to remember here for this diagram is going to be the coronary sinus, which is the vein which will be collecting all the venous blood from the cardiac tissue. All right, and again, it drains directly in the right atrium. It doesn't drain neither in the superior vena cava or the inferior vena cava. It drains directly in the right atrium. This is again a 2 stars diagram. A 5 stars diagram is highly important diagram. It's showing the intrinsic conduction system of the heart. SA node, AV bundle, bundle branches, right and left Purkinje fibers. This diagram is highly important. 5 stars diagram. A must be on your test is going to be a 10 stars diagram here. Diagram showing the basic waves of the EKG. P wave that marks atrial depolarization, QRS complex which marks ventricular depolarization, and the T wave which marks the ventricular repolarization. Also very important to know the name of the intervals and segments on the EKG. So remember here P until you reach the Q wave. This is going to be the PQ interval. From the S wave to the beginning of the T wave, this is going to be the ST segment. From the beginning of the Q wave until the end of the T wave, this is going to be my QT interval. This is going to be a 10 stars diagram, must be on your test. Very, very important. Other diagrams that we have discussed, it's not on those slides, which would be the sites for auscultation of the different valves on the chest. Remember, sites where you can hear best the different valves on the chest of a patient. This is a 5 stars diagram. You're gonna have this diagram on in your textbook, in your diagrams slides on Canvas as well. This is the ones that we've discussed. Remember, if I'm looking at the left sternum margin, this is the site for me to hear the pulmonary semilunar valve. Right sternal margin in the second intercostal space is going to be the site for me to be able to hear the aortic semilunar valve. If it was defective, it creates a murmur, so it can be heard best in the right sternal margin. Down here in the lower part of the sternum, this is where I can hear best the tricuspid valve. At the apex of the heart, in the mid-clavicular line, in the fifth intercostal space, this is the point where I can hear best the mitral valve. All right, so very important to remember that the pulmonary trunk is crossing from right to left, so you can hear it on the left side, compared to the aorta is going to be crossing from left to right, so you're going to hear it on the right side. This is what gets many of you confused. All right, just remember that they are crossing, so right side to left, this is pulmonary trunk. From left to right, this is the aorta. Any questions? Any questions?